Welcome to Oncology for the Inquisitive Mind, the only podcast you'll ever need to explore the wonderful world of medical oncology. Today we have a very special guest, Professor Sabe Sabesan. Sabe is truly an Australian story. Having grown up in Sri Lanka during the Civil War, he completed his high schooling and waited to start medicine after being accepted. Unfortunately, this never happened as the universities did not open, and Sabe accepted a scholarship to travel to Australia to complete his medical training. During this, he never lost sight of his passions and ambitions, and while I don't want to give everything away, Sabe has ended up in Townsville as a professor, leading many policy-changing reforms that will hopefully improve the lives of our patients and our colleagues. Thank you for being on the show, Sabe.
Yeah, thank you for having me both.
It's great to have you, Sabe. You've got such a wealth of experience, but as we always like to do on this show when we have illustrious guests is, number one, use the word illustrious a lot, but it's very, very fitting. But we want to start at the beginning, and all of our guests up to this point have had not what you would call a typical path to medicine, but Josh touched on a few of the salient points. But we'd like to hear it in your own words. What was the experience of coming from Sri Lanka, a country whose origins, ironically, we both share, and ending up in a place like Townsville, Flinders University, studying medicine, which sounds like it was, from a very early age, quite a passion of yours?
Yeah, it is an interesting journey. Definitely, growing up in Sri Lanka, I would say it has shaped my passion because my father was a senior bureaucrat administrator for rural districts, and he never wanted to work in a metro district because he always felt he didn't have anything to offer. So I had that in me all along, and then growing up in the village, always see the difference. Even in Sri Lanka, having to take my grandparents to a doctor takes an hour on a bicycle with three of my friends having to accompany with water, pillows, and mats for the hospital. So it was always there even as a child. And then I did biology, so maybe I ended up in medicine because I did biology, because in Sri Lanka business and commerce and arts were not sexy. So then I ended up in Flinders, lucky enough to meet a lot of country friends in the hostel, and also did a lot of rural placements, and that's how I ended up in Alice Springs. And once I was in Alice Springs, it just opened up my eyes, and there's actually life outside metro areas, because I was led to believe that the life only happens in Adelaide at that time, and if Adelaide life wasn't good, you go to Sydney or Melbourne. But I ended up in Alice Springs and had the taste. So when I went back as a final year student to finish it off, I thought I need to do internship in Alice Springs because it was such an experience as a student. But I was struggling at that time because I was led to believe that to have a job in Metro, you have to have a molecular PhD. So I was doing molecular biology during my vacation holidays, and even had a couple of papers on molecular science. So after Alice Springs, I saw an ad for Royal North Shore, went to Royal North Shore for RMO year, again, molecular science, and then ended up in Royal Brisbane. I even had a bench in Queensland Institute of Medical Research. And I was going to do a molecular PhD until my son was born in the last year of my advanced training. And I was pipetting for the first time as part of my PhD, because I was pipetting all my life, but this is as part of my PhD. And I realized I'm going to Townsville because it's regional thing. I always wanted to be in a regional place. What am I going to do with this molecular PhD? So I stopped it, finished that still year, took a gap to spend some time with my son, and finished my training in Royal Brisbane and ended up in Townsville. And then the rest happens since 2004.
That's that's I think I'm speechless. That's already quite a remarkable story, and we haven't even really hit your years as an oncologist. And although I do not share your heritage, I definitely share some of the sentiments of almost being a father and trying to figure out the next steps when it comes to a career. Although I think you mentioned that you finished your training in Brisbane, Royal Brisbane. I'm a ex Royal Brisbane person myself, and then you ended up in Townsville. I note that you have still completed a PhD. Now, I was wondering, was this in your molecular biology area, which you said you sort of decided this isn't what I want to do? But what did you end up funneling your passion into for this?
So what happened? So I moved to Townsville, and I was actually at that time one of two oncologists, but then the other guy left soon after. So I was by myself for about 3 or 4 years. But I still realized a lot of patients were traveling to Townsville to see me, and even from Mount Isa. A lot of the time for 5 minutes consultation, 10 minutes consultation, driving 10 hours, flying 3 days. And I thought this is not the right thing to do. These people have limited survival, and we are literally stealing their days of their lives just simply by making them travel. And that's how then I bumped into telehealth, and then started doing video conferencing to Mount Isa mainly. Um, and that time, I didn't have any experience with system reform, implementation science. It was purely there's a problem, let's fix it. That approach. But if I knew different things, it would be different. But certainly, it was fun because you just go through it without realizing what the depth of the water is, and then realize, oh, this is deep, but you still need to swim across and survive. So I actually then started the teleoncology, created the network, and you realize at that time I was by myself, but still having to do telehealth for the fact that the patient's time is more important than my time. So we were innovative in there because in a regional centers, changes can be easy. So we actually used some of the existing FTEs to employ GPs. So we employ a few GPs to do review clinics, so I could just do the new patients, and then started doing the teleoncology. And while I was doing teleoncology, I was really criticized by all my colleagues in Brisbane and even physician colleagues in Townsville. And I said, the patients are happy, mate. What's the problem here? And the attack was so relentless that I actually had to do research. After 3 years of gap, I had to now do research. So I asked one of my RMOs, said, can you just send a survey to these 55 people we have seen so far and just see what the hell they are saying? So that was our first paper on telehealth, patient satisfaction, and we published that in IMJ. That's actually started giving me the levers to calm people down and to generate the evidence for the benefit of telehealth. And then the thanks to all my colleagues who were critical at the time, they gave me the ideas for my PhD. So one will say, oh, but yeah, patient may like it, but safety may not be good. So, and then someone will, oh, this is too costly. This is too dangerous. So I basically made all of them as research questions. And when we had trainees coming to our department, I gave Brian Chan the safety question, Darcy Tucker the cost-effective question, and they all published in MJA. And at that time, one of my academic colleagues said, "Why don't you enroll for PhD by publication, and just keep doing what you are doing, but it doesn't cost you extra time?" So I reluctantly enrolled and did the confirmation. That was a bit of a work, but then I did a couple of courses on epidemiology and qualitative research, and kept publishing while I was expanding the telehealth, telechemo models. And yeah, in 4 years, we actually finished the PhD, using the implementation science frameworks. So that's how I ended up doing PhD. because my colleagues challenged me to prove that telehealth works.
A lot of people who are on the verge of selecting a PhD often ask, is this actually going to help? But Sabe, I think you've answered that question by actually addressing a question that was posed to you. And that attitude of grabbing the metaphorical bull by the horns and seeing a problem and fixing it, I'm imagining stands you in very good stead, or stood you in very good stead, for your current role as the head of the Clinical Oncology Society of Australia. So I was wondering if you could ask and please tell us as much as you can about COSA's role. It's currently celebrating the 50th annual meeting in Melbourne, and obviously is an organisation that has roles and focuses in advocacy and workforce challenges, training and education. But please, if you could tell us about the goals and what you hope to achieve as its head of COSA.
So at the moment, I'm president-elect of COSA. So the COSA has been an important vehicle for me. And I think for all the oncologists, aspiring or current one, who feel that they are voiceless or they are powerless, we actually have, as a profession, we have power within ourselves simply because of the profession. But I collectively call these things levers. So these are the clinician levers we are privileged enough to have access to. So in 2012, as part of my PhD, or while I was doing PhD, I actually joined the COSA because to present some of your abstracts, you have to join COSA. So I became a member. And then when I was talking to people like Nick Pavlakis and John Zalkberg, David Goldstein, and I realized there is a group of people and a group of body that looks like something inspirational there. So then I joined a group called Rural and Regional Group within COSA. COSA has multiple groups, so people can join and really make the most out of it. So I joined the Regional Group. Within few years, I became the chair of the group. As a chair, you sit in the COSA council. Once you are in the council, you have open canvas. So I basically took the teleoncology, and I proposed that we develop clinical practice guidelines for teleoncology. So we did that through COSA because that is a credible platform, a multidisciplinary. So that's actually now quoted, referenced by the ASCO guidelines for telehealth. So we did that work, and while I was with that first success, you kind of think, oh, looks like this tastes good, so you can do more. So then, while we were doing telechemo in Queensland, and we were doing telechemo model in Queensland at that time, extension from my PhD, and it was a state model, and we were doing immunotherapy in all the small towns and BEP in Mount Isa. So I asked the question from a lot of the trial groups and industry in 2000 and probably 13, 14, we are doing all this toxic stuff on tele. Why can't we do clinical trials for simple medication trials? And they said, oh no, cannot be done because there's no national policies. Then I thought, okay, that is the beautiful situation to be in. If there's no new policies, you can write new policies. It's very hard to change all policies, but it's easy to write new policies. So then I proposed the idea of teletrial at the COSA Council. And then in end of 2016, through a national collaboration of 40 organizations and state governments, through COSA, we released the COSA Australasian Teletrial Model National Guide for Implementation. From there, because it's COSA again, we were able to do a pilot in Peter Mac, Albury Wodonga, Westmead, Dubbo, and whole of Queensland to show the feasibility of a teletrial model. And with that data, Commonwealth was changed the policy. They created a national teletrial compendium. And again, I come back to the COSA. We said, now we need money. If we have a model, we need a program now. So because it's advocacy body, if you want to make an appointment with a minister or politician, you actually will get it easier than if you are ringing by yourself. So we managed to get some traction from politicians and got that 100 million from the then Liberal government. So and now with the state governments. So basically, without COSA, I don't think we would have had the credibility to actually go after the reform that we are hoping to achieve now with the National Teletrial Program. And then you asking the question about what I want to do with COSA. So I thought uh, while we were doing the 100 million program, the uptake is still slow. Even though state governments got the money, infrastructure, coordinating centers, and the program to me feels like all other programs, government programs, where there's significant wastage of money and the program goals are not achieved to its fullest. And then I realized it's probably because of the health system culture of inertia, apathy, lack of care for a big purpose of reforming rural regional system. And it's actually only one of my friends from COSA, Haryana Dillon. She was the psycho-oncology group of COSA. Last year, she rang me and said, Sabe, you need your own voice now because you are wasting time talking to the wrong people. So I said, oh, okay, that makes sense. So she nominated me, and then I said, okay, I'll stand for the election with two agendas. One is advocating for better workplace culture as a foundation for workforce wellness, and then implementing teletrial model as an exemplar for creating a networked regional rural system in Australia. Two agendas. And yeah, so I'm elected. So I'm looking forward to doing more of that stuff.
My question is simple. Do you ever sleep, Sabe?
That is actually a very important question. Um, it is quite interesting because I would have ideas at 3 o'clock in the morning, but I will get up and write down because I didn't want to forget. Sometime I can't fall asleep because I was so pissed off with people who are blocking any progress of these models, because these are the people who on their strategic plans said they want to do closing the gap, care closer to home, virtual models, but then you go with the model and they are blocking you. So I was morally injured all the time. So that also was my problem because I was angry and frustrated, so that affected my sleep. And I had PTSD from the war, so it kind of felt like PTSD because PTSD is about violation of human rights. So I felt like the system was violating our passionate clinicians because the clinicians want to do the right thing, but then the lip service is where the contradiction is. So I was going through with that kind of trauma, but fortunately I had my family is fantastic, and I do a lot of recharging, run, kayak, sing. I'm learning tabla at the moment. And only maybe 12 months ago, maybe 2 years ago, it just didn't feel right that even though it was challenging and rewarding and you are driven, but that way of happiness and sadness and ups and down, I thought, no, Buddha wouldn't be happy with that kind of approach, even though I'm not a Buddhist. So that's how I actually then asked the question one day, why am I doing a lot of recharging here? Why am I discharging in the first place? So then that's the first time I actually looked inwards, because I was looking outwards all the time and say, oh, what can I do here? What can I do here? But I never stopped and looked at me. And now, actually, I'm actually learning to sleep better, and I can manage my thoughts better and rationalize my thoughts. So that well-being as a duty of care to yourself has become an important part of my life, and that's what I want to make it as the next, however long I'm alive, going to make sure that I live a peaceful life.
I can hear the fire that sort of lights your passion, and there is honestly nothing better to any burgeoning clinician or experienced clinician to really know that there is the avenue to make important change on a national and potentially international scale. Sabe, what you said, there's so many questions. So I'm going to try break it down and I'll just ask one. What do you think? So you're COSA elect now, you've kind of got this framework to try and push your agenda or the agenda which will hopefully improve the lives of hundreds of thousands of people if you look at everyone who's affected by cancer. What are the largest barriers that you see at the moment and potentially enabling factors to rolling out this Teletrials, I guess, this program and this national structure? How do you intend to kind of weave the forbidden fruits and deal with the politics and I guess navigating stakeholder management, which is a term everyone loves to use these days? What are your kind of pillars to kind of get this to the next level?
So the pillars really goes back to implementation science, because that's what I didn't have before I did my PhD. Before it was like jump in, but now there's actually a methodology for jumping in. So I kind of you figure out, but then you become wiser too if you're prepared to listen and learn from others. That's another thing actually. One thing doctors are not good at is listening to other people and changing themselves. So certainly a learning person is a good place to be in. So we published this article called "The Art and Science of Clinicians Leading Change" in MJ, I think last year or year before. Just summarized what steps clinicians need to take to effect the change. So what we found out, we need the implementation science methods. So that is, what is the problem? Is it a problem? Why do we need to do something about it? Who are the stakeholders? What is the solution? And the solution need to be co-designed. And then stakeholders need to be carefully chosen. So we got to follow that step first. So I feel like through the teletrial program up to now, we have followed all the right processes and make sure that it was addressing the problem of disparity in access. It is based on pilot programs, so it's really it ticks all the implementation science frameworks. So that's part one done. So I'm happy that we are doing the right thing. Then what we find is missing is actually now, how do we overcome the so-called barriers and what enablers we put in the 100 million? There's all these enablers put in. The enablers were put in for the barriers that were identified during the pilot. So we also happy that we got the enablers. But what happening is, I'm not calling the barriers anymore, because no one put it in front of us suddenly. They were actually there already. So now I call them reality. So our job now to decide whether we accept the reality or influence change in the reality, because we can't control anything. So what we decided, when we look at one of the issues with the national programs or reforms, actually it's a multi-layer issue. So it is related to the pyramid culture, the autocratic hierarchical culture that normally focuses on its own agenda rather than what's good for the community. But fortunately, what happened in all the health systems, the strategic plans actually designed to make a difference to the society. But what happens in day-to-day life at all layers, they only focus on what keeps their jobs alive, or what the key performance indicators that really don't serve well of the communities. So I think the major barrier we have is from top to bottom, all layers, including clinicians, that the whole system, we are not aligned with what the Australian societies expect of us as a system. And that is the barrier. And that's why we were proposing that barrier, I collectively call it health system culture. And so if you want to reform anything, we have to forget the pyramid cultures and then go for a democratic cultures, and that's where the system lasagna model comes. And so this is what we are now trying to do. We are trying to make sure that these programs are now adopted by all layers from top to bottom. That is called purpose alignment. So the ministers and the health secretaries and the director generals need to actually take this as $100 million transformational program, direct the next layers, and enable the next layers to enable the layers below to enable the clinicians to deliver a network clinical trial system. So that's what we are now focusing on. How do we now get the system layers to absorb this teletrial source as part of cooking a tasty teletrial lasagna? And that's where the levers come in. So we have clinician levers, and then part of the levers is self-care, because we have to really remain full and energetic so that we can keep influencing the change.
Sabe, I can just see or hear the listeners to this episode being absolutely inspired by your proactive, solution-focused approach, and the mindset that you bring to a system that, as anyone who has worked in it, no one will say it's perfect. Everyone will be able to agree that there are a lot of, as you say, sort of barriers, but there are also a lot of levers and people who have the capacity to change. And listening to you speak about that with such, as Josh said, such fire and such passion, I'm ready to run through a wall right now. But the other part, and you've obviously got very personal experience with this in the genesis of your own medical training, and a system where the problems are perhaps more obvious than other areas of Australia, is the rural, regional, and particularly the Indigenous areas. You spent your formative medical years in Alice Springs, and for our international listeners who don't have access to an atlas, Alice Springs is pretty much smack bang in the middle of Australia. It's very, very far from any other major centre, and just by the virtue of its geography, but also several other issues, Sabe, you're much more qualified to talk about than I am. But it is a challenging medical place, but also a very rewarding medical place. You've talked sort of almost at a very macro level, Sabe, about the issues affecting the system writ large. But would you be able to tell us about your experiences in working with Indigenous communities and in rural communities, and some of your no doubt brilliant ideas on how to fix the various inequalities and inequities that are to be found there?
Yeah, this rural and Indigenous health, it is a complex, because geography is a major barrier. We can't undermine that or underestimate the impact of geography. But I always felt that if Department of Main Roads can build bridges and highways to connect towns, then why can't the health system do the same thing through a virtual network kind of system? So that's just a oversimplification of a complex problem, but we got to start somewhere. So these communities are very isolated, and they are really run as silos, I would say, disappointingly, even within LHN or LHD or health HHS in wherever the states you are in. The mothership, the referral center, treat these smaller places almost like, I don't know what the word is really. They do not treat them like their children or part of their network. So it's almost like there is a sense of entitlement by the teaching hospitals that these places somehow are existing as burdens for the whole system. And with that kind of attitude, that's even by the doctors, managers, CEOs, they all, my experience has been a lot of them actually don't think that the only way you can look after this rural and remote Indigenous town is through a network system. And that's where the telehealth comes in. It creates networks. So certainly the travel by the patients is actually not ideal, because what happens a lot of the time, they travel with one escort, and then the rest of the family actually don't know what's happening. And especially for indigenous communities, coming from a rural village in Sri Lanka, we very big families. The whole family wants to know what's wrong with the uncle. It's the same thing in a lot of the indigenous communities. But what we are doing is, by making them travel, we're actually denying the family access to the holistic care. So what I found, when we did the tele-oncology to indigenous communities, we actually encourage all the family members to come, sometime 10, 15. And then we are talking about the cancer and prognosis. And then you identify 2 or 3 people who are movers and shakers in that family. So we then assign compliance and medication compliance monitoring to those people. So almost like educating the whole family on the disease. But also what I found, the knock-on effect of that is, when we talk about lung cancer and then talk about smoking, suddenly the whole smoking cessation prevention education, it's become as a segue. So that the consultation become a segue into preventive education for the whole family. So there's all these disadvantages in those communities, but it can only be fixed by the system, and that's the system is pouring a lot of money into it. But then the problem is that is poured into a silo rather than poured into a network with different KPIs for a system performance. So at the moment, the system is rewarding silos, but what we want to see, the system should be rewarding networks, so that the rural, remote, indigenous communities could feel part of a larger network of health system, where doctors partner with doctors, managers partner with managers. It may be utopian, but I don't think it's too hard to achieve.
I think that's as they're wise words, looking at a way to increase engagement and equitable distribution of healthcare, which not just Australia but many countries, I think, find challenging. And I think this almost links back to your lasagna model, doesn't it? Where you're talking about having a flat structure where you have people engaging with other people. One of the areas that you mentioned, well, I think we're heading back to COSA, but one of the COSA, I guess, aims is looking at workforce challenges. And what they've found in some local research in New South Wales is the majority of clinicians, so oncology clinicians and registrars, are burnt out. And you mentioned a number of things that you do yourself, Sabe, to, I guess, improve your mental health and manage it. And aside from the flat lasagna model, what do you see as the biggest future challenges to our current workforce and ways we can potentially improve that? And I mean, you've spoken about teletrials, which is the first tick, engaging general practitioners in your review clinics as well is just, a remarkable feat of being like, there's only one oncologist, but we can have people to do the majority amount of the work, which, most people can achieve in the healthcare setting. Would you mind elaborating on that a little bit?
Yeah, I think the workforce is always a challenging. But my feeling is that there's something missing with the workforce planning and workforce growth, because when I was a medical student, the number of medical intake was 1/4 of what we have now. But the problem gotten worse. So I don't know whether it's purely number, whether we are wasting, there's a wastage, or whether there's demand. I honestly don't know what the answer is. But that will be a complex issue. But certainly, my observation has been, if you have a good workplace culture doing multiple things, you will attract the workforce. So my example in Townsville, within 4 or 5 years of us doing teleoncology stuff, we started attracting people, and now we are 7 medical oncologists, 2 advanced trainees, we have a research assistant, we have basic trainees. So the people will come if we have a good culture, in terms of caring for people, but also caring for the colleagues, and work in teams and make sure we look after each other. So whatever the solution there may be for workforce distribution and challenges, obviously that's outside our control. So that's where I was actually thinking, okay, as a profession, we could do two things. One is, um, whatever we have in our departments, we got to make sure that there is a vibrant, kind, grateful environment. And I don't think we are doing that fantastically in our medical profession. There's so many egos, so many agendas, and I'm pretty sure once you have egos, you waste time. And so if we can learn to work in high performing teams, look after each other. That's why I actually, part of the lasagna model is flatten the pyramid from at all layers. That includes our medical profession. So make sure we remove unilateral decision making from medical profession. Make sure we have a collective decision making at management level. We have multidisciplinary teams. We are collective, but at management level, make sure we remove unilateral decision making, and so that every medical oncologist feel like they have a voice, they have empowerment, they have free thinking, free speech in a democratic society. Because I do hear from a lot of my colleagues that they feel voiceless, even with their own directors who are medical oncologists. That is not acceptable, and that we can fix it. But I want the system to actually force that reform onto the system. So, functioning as teams through a team governance is an important step for our profession. But individually, as I said, we all have a responsibility for ourselves. So what I realized after so many years of searching, that I'm just one person out of 8 billion people. I have no control over any other humans. So I would not control anyone. I would not judge anyone, because I'm not qualified to do any of them. So all I could do is focus on my purpose, focus on kindness and gratitude, and then keep looking at my levers and see whether I can influence change in the things that need to be changed and accept the things that don't matter. Um, and then also I heard an acronym called CAR, CARR, not Lamborghini or BMW. It's really CARR, to manage external. That is, change what you can change, accept what you can't change, remove yourself if you can afford to, but I put in there, remove the other person if you can afford to. And then rise above if you can't afford to remove yourself. So with that, I find it quite powerful, because just look at the reality outside me. But my number one focus is make sure my tank is full all the time because of my gratitude and kindness. These are the chill pills. We actually published that in MJ Insight last year. Chill pills for minimizing energy discharge. Um, so with the chill pills, I keep my tank full. I don't control anyone. And then if I want to rise above, then I find my levers and then see if I can influence a change in the reality. I think if we can do this, we will remain well. And if we remain well as a profession, I think we will be more productive, and maybe we remain well and longer in the system. And also, we might inspire more trainees to do medical oncology if we are well, inspiring people who have inner peace, as well as people who are able to create outer peace. Then we might inspire our next generation for workforce. That's within our control.
Sabe, that is an absolutely perfect segue. Although I must say you're going absolutely above and beyond the call of duty on today's episode. You're not just giving advice to oncologists who want to change the world, you're giving advice to anyone else who wants to change the world. So thank you for that. But the question I wanted to ask actually is about, as you said, the next generation, because you've mentioned culture so many times as something that can, and in many in many cases needs to be positively changed, and as pie in the sky, for want of a better phrase, that it might seem on first listen, inspiring and teaching the next generation of doctors, oncologists specifically, is a sustainable way to do that. And you are heavily involved in education and mentoring. Is that correct? I understand you've been involved in part of the medical program and the medical curriculum at James Cook University. Could you tell us more about your experiences there and what you see, I guess, in the next generation? Hopefully, it's all very positive.
Yeah, I think at the moment, we have in medicine, we are fortunate that we got passionate, smart individuals. There's no question about it. So it's a pleasure to teach these guys. And so what early in the piece, 15 years ago, when I was part of Cancer Council Australia, I was part of the ideal oncology curriculum, and because regional place again changes at that time easier, so I came and took over the curriculum and coordinated the whole oncology curriculum for JCU. And now I have delegated, so there's enough people to do that work. So what I now focus on for undergraduate is actually not leadership, because I don't like the word leadership because that's misused a lot. So I'm trying to teach leading change as a skill set, because anyone can lead change. Um, so that's certainly now focusing on that. And then the whole well-being piece is also part of the leading change. Because as a doctor, you're leading change on a daily basis. So then why not do it properly? So that's one of my focus. And then for the advanced training, we were part of the Queensland Medical Oncology Training Network, 7-8 years ago. So I'm not too much part of it now, but certainly at the beginning we were instrumental in getting a statewide network with Melissa, Eastgate, and all the nice people in Brisbane. But certainly now what I am seeing is that more than ever, the need for self-care is probably the most important lesson that our trainees need to learn, because the medical knowledge itself, you could Google search that stuff. So you don't need to know everything, because there are pathways and there's guidelines, there's algorithms, there's AI. But I think the fundamental issue now I'm seeing is that in an ever-changing, highly demanding, entitled environment, how do you find joy on a daily basis and rise above all the challenges the external stakeholders put on you, whether it is patients, families, your nurses, doctors, management, whoever that is? We have to become foolproof, not thick-skinned, actually foolproof in terms of protecting our energy level. So I have now decided, even for my change myself, is keeping my tank full is my number one purpose every day when I wake up. Because if my tank is not full, I'm no use to myself or anyone else. So I think that's probably what's missing, because every other thing you can teach. You don't even need to go to any educational sessions. You just listen to ASCO updates. But this particular self-care and keeping the tank full so that we can be helpful for ourselves, helpful our families, because our kids rely on us. Our partners rely on us. So we can't just carry on behaving like what we've been as a profession and asking for extra sympathy because we are doctors and we are working too long or whatever. But I think we have a responsibility for our families, ourselves, but also for the rest of the system that relies on us. But that means our tank has to be full, and I think that has to be a number one focus of all the training societies. And Demi is really keen on that idea. He is the chair of the MOGA, and we were talking only few days ago about two things. One is MOGA advocating for cultural reform in collaboration with COSA and CNSA and other organizations, but also then pushing the wellness agenda over and above having cupcakes and tea breaks and that kind of stuff.
Yes, I do love the there is a famous ophthalmologist from the United States called Dr. Glaucoma Flecken, and he likes to post lots of satirical little videos, and one of them is when the doctors complain medical administration gets them pizzas as a thank you and I guess a way to shut up. Not my question, but just a sidebar. Sabe, what you have achieved over the last 20 plus years is nothing short of miraculous. And you've really been a tour de force of what changes you can try and make as, I guess, a health professional. Our final question, and one that we ask all of our special guests, is this. If you had the ability to talk to yourself, your younger self, when you started your journey, what pearls, and you've covered this, but I'd love to hear if you have anything else. What pearls of wisdom would you have?
I would say what would have made a difference to my life and my well-being would have been two things. One is the correct way of self-care. So if I knew the purpose, chill pills, and the levers, then if I knew how to keep my tank full from the day of my high school or day of my med school, I would have been much more peaceful and probably much more effective in my approach to external stakeholders. I may not have burnt out and just up and down life. So certainly that would have been important. It's like learning swimming. If you learn the correct strokes, you can swim longer and enjoy longer. But if you learn the wrong stroke, you might swim longer, but you may have injured yourself. So that's one. And the second one is, if someone told me that there's a such thing called implementation science, and that actually gives you steps for approaching and designing system changes, or any, not just system changes, solution building for your advocacy, I would have actually been much more peaceful because I didn't need to learn the hard way. So I think those are the two things. If someone told me, at least in my med school, those two things, I could have been much more effective, and more important than that, I may have prevented some of my burnouts I experienced throughout my life.
Sabe, we've had quite a few guests on this show. They are all knowledgeable, they are all wisdomers, but you are incredibly inspiring, and we cannot thank you enough for coming on and sharing a little bit of your inspiration, a little bit of your fire, and a little bit of your drive with us and your audience. We appreciate it so much. Thank you.
And thank you for having me. And really, I get excited because I really see there is a light at the end of the tunnel, and medicine is a fantastic field. And, we can help patients, we can drive system reforms. And I'm ever so positive that if we take these right approaches as part of our curriculum, and I think we will create a well and a productive workforce. And thanks for having me.
Truly a goal that everyone listening can aspire to you. So join us next time on Oncology for the Inquisitive Mind, where we will be talking about uterine cancer, endometrial cancer, a cancer that is not really seen in several centres, several non-specialty centres, but deserves a bit of a spotlight nonetheless. So we'll see you next week.
See you then. Bye.
Thank you for listening to Oncology for the Inquisitive Mind. You'll find previous episodes on our website, along with weekly posts, resources, and links to our Twitter and LinkedIn pages. Check it out at inquisitiveonc.com. That's inquisitiveonc.com.